this lady, she will tell you a bit of her story, but you've been landed and you understand that she jumped out of a window and she has a burn. That's all you know.
Sarah, my name's Kate. What's your name, sorry?
Debbie. Hi,
Debbie.
Sarah. My name's Debbie. I'm one of the plastics doctors. How are you doing?
Okay.
What happened?
House fire.
House fire. Okay. How long ago was it? Has it just happened now?
Yeah, just
Okay. Okay. Were you on
Set the bed up, Debbie, just whilst you're talking.
Yeah. Yeah. So we're setting it up.
Theory.
Fine. Fine. It's up to about 45 degrees. Okay. So where were you? Were you at the top story or were you at the bottom story?
Just put this in your finger so
You were in your bedroom. Okay. And what happened exactly? Was it a fire or was it just the smoke? Was it a fire as well?
Yeah.
Okay,
put your head back down.
so just put your head back down. So if we could have somebody else to help, if there's anyone around. Yeah, thanks. So could you possibly hold until we can get somebody to get a collar, cuff, collar, and sandbags and tape? If you just hold it for now, that's all right. So we'll put.
Sats and our blood pressure, heart rate.
Have you connected up?
Yeah, everything's connected.
We'll put 100% non-rebreathe mask. That's all right.
Put this around the edge, Chrissy. You could just hold it so I don't have to lift our heads.
Just pull it off just so slightly so I can just speak. Can you still speak okay? Is that all right? Okay. So how long were you trapped for?
Oh no, I jumped out.
You jumped out. So can we have some IV morphine as well, if that's all right?
Yeah, we'll need access. I can't do access. Is
Okay.
there someone available that can... Thanks.
So we could get, if we could also...
So who are you?
Could we possibly call Fast Bleep, the anaesthetist, and the general surgeon, the crash team, please, the trauma team, please?
Sats 100, Taki 130.
130, okay, fine.
Whilst you're
Okay.
talking, I'm just going to feel down your arms and your legs, okay? And just tell me
Is there
if it
any
hurts,
blood
okay?
or anything that we can see around or on the floor?
There's no blood on the
There's
floor.
no blood. Okay, fine. Fine. So airway. So we've called the anaesthetist. We've got that in, and I'm assuming we can't feel any stride or anything like that. Listening. Can I hear anything? Listening.
No, listen to her chest.
Yep.
Speaking.
Is the chest? Is that all right?
Yeah.
Seems equal.
Okay, fine.
Down here.
Any blood pressure
Elbow.
at all?
The blood pressure. Let's put it up.
Tell me if any of these ribs are hurting, okay? It's alright?
Coming up. 80 systolic.
80 systolic.
Okay, so
Yeah, so we have two large blood cannulae, both anticubiphosphate. We take off bloods for cross-match group and save. We do an ABG as well, please, and fast track that. And then we'll put up 250 of Hartmann stat, and I'll just calculate it now. So do you know how much you weigh normally? Okay, so about 60 kilograms, something like that. Okay, so if we...
Which leg was hurting, Sarah? Leg's fine, so it's just your left elbow now?
Yeah, that's fine. That's fine. That's fine. That's fine. Could we get some fluids when you're ready? So we can have the 250 Hartmann stat, but then it will be 4 mils times 60 kilograms. We'll do the 4 mils, and we'll do that. It has started now, so we'll do half in the first 8 hours from now, if that's all right. And we can catheterise so we can just see how she's doing. Is it improved at
Another
all?
blood pressure.
60 kg, is that right? Yeah?
There's no circumferential burns anywhere, is there?
Percentage, did you say, sorry, Ben?
Blood pressure is 78 systolic.
Oh, it's going down.
not looked on the back.
78 systolic.
Yeah.
Stats are 97%.
Have we got IVF?
Okay, good, good.
130.
We have got IVF. Okay.
So yeah, percentage-wise,
Get it up.
about 20%. I'll do a full London Browder chart in a second, but
1, 2, 3, 4. About 18.
18,
now,
yeah,
but we
yeah,
haven't
yeah.
seen a back or else.
yeah, catheterised, please. Yeah, fine. So yeah, so in terms of, I'm just worried there's any other injuries. So with
I'm just going to have a feel to see if there's any catastrophic bleeding behind.
yeah, what we can do is we can log roll her, supporting the head. So if we'll pretend we're log rolling it now. Is there any other injuries at all that we can see, or
Nothing that should
any
No.
other burns?
Painful left elbow.
Left elbow, fine. So we can, when the ortho team come, we can try and
remove
splint
this.
that. It's not. I'm assuming it's not abnormally distorted. That left arm.
Okay.
She has a bit of pain. She probably sprained it, but in your second survey, you might request X-rays, right?
Yeah.
So now you're
Yeah, we'll
covering
do
all.
we'll do the full trauma series as soon as the ortho team
Yeah.
come down. Fine.
Fluids are running.
Okay. What fluids are you using?
So we've now used Hartmann's. We've now got the
Put it up.
full Hartmann's.
Yeah, put it
We
up.
can't hang it, it doesn't hang because it's in hole.
Did you open it up?
Is that what it is?
Oh, true.
Happy for surgery.
Yeah.
How about the abdomen? Is that soft, tender?
Have a
Have
feel?
requested an anaesthetist.
Have we
Yeah, we've requested an anaesthetist and we've requested the trauma team.
Has anybody called?
Did you request them?
We fast bleep them.
Oh, did you? Okay.
And so you,
You might need to call them.
yeah, can someone call the anaesthetist and ask them to come down immediately? Is that all right? And the trauma team.
Okay,
Thanks.
on the way. I've just called them. So,
Thank you. Sorry, you're saying abdomen, was that?
how it feels?
Yep. How's that? Is that very painful? Is that all right?
It's all right. Yeah.
Yep. And no chance to be pregnant at all. So a couple more questions. So, do you have any other medical problems at all? No. Do you take any regular medications? Sorry. No regular medications. When was the last time you ate anything at all? Breakfast, and I'm assuming it's so late now. Fine. Bye bye. Okay. So, any other injuries? You fell from? I'm assuming you jumped out the window in your bedroom. Okay. And is anything else hurt? You said your arm hurt. You had your. Did you?
Even more actually now, 143.
Had
Okay.
access or given analgesia?
Yes, we have. We've given it a 0.1 mil of morphine per kilogram. So we'll give them
Is there
some.
any internal stuff you think?
This is what I'm thinking.
Abdominal pain.
Got no abdominal pain. There's no major distortion to the arms and legs. Nothing really that I need to kind of manipulate now. So I'll give more analgesia.
In the scan?
I'll as soon as they come, I'll do a fast scan. And when she's stable, we can do CT. But she's not stable for that yet.
So airway,
So,
breathing,
airway,
Is there any
breathing.
issues?
No, when I
So
listened, that was.
Systolic blood pressure.
Have we done bloods?
We've done bloods.
Yeah,
We've
we've
sent
done
it all
bloods,
off. We've done the ABG.
Have we had the
We've
results,
got results of any of that
because
yet?
That should come back quite soon.
Yeah,
Can anybody
her-
roll a...
Her lactate is 7.1.
Okay, can we call
The result didn't come out. You might need some other gas.
Okay.
fine. Can we call the general surgeons as well and get them to come as soon as we have already
Your
asked?
helper. Shamari, please help them.
So general surgery, right?
Hi.
Yeah, we do.
So we have a 18-year-old girl who's just jumped out of the window. This is about an hour ago. We can't really find the reason for the decreased blood pressure. So she's stage 4 shock now. She's not really responded to fluids. It's not from the burns. It's from something else. It's either from the abdomen or from. Are you gen surge? Are you?
Research, yeah.
So we just need to do a fast scan, I think, just to make sure it's not intra-abdominal. I don't think it is.
Will I find his number in your phone?
Okay.
I
think, Let's try BP cuff bigger one if we can.
Yeah. Let's try on that arm.
She's got this really painful left elbow. Just
Yeah.
Okay. Well, let's
go calf if you want.
Yeah, could do. Thank you. So just looking at the legs, how are they? They've got a pulse. Have they?
Pulse is fine. She's neurovascular intact. Distally, they're soft. She has no concerns.
No.
The bulk of her burns are more upper torso.
Yeah. And when I'm listening again, so I'm listening over the chest. That's still.
That's actually fine.
And
she's a little tight, I think, due to her burns.
But she's expanding. Okay.
She's expanding fine.
Okay.
She has a little some neck pain.
Yeah.
Put a collar on.
Oh yes, we've got collar, we've got sandbags, we've got tape. We did that straight away.
Excellent. Do you want to know blood pressure?
Yep.
In your cup?
And the gas that we've just taken, do we have results for that?
It's coming back. Doesn't come that quick.
It does.
The queue is the machine.
Yeah.
Blood pressure is 120 systolic.
Good. So I guess we could then just do a full secondary survey, couldn't we? So we could. You still? How are you doing? You still with us? How's your pain? Do you need a bit more pain relief? Yeah. So we'll give you some more pain relief. So she's A for AVPU. We could do a blood glucose. We could. Yep. And we'll check the pupils and just make. Did you have anything to drink before? No. And any. Sorry, we always got to ask any illegal drug use at all. Okay, fine. And so she's responding fine.
What do you want to give pain relief wise?
Well, we've given morphine at 0.1 mils per kilogram, haven't we? So let's just give another 5, please. Let's give her 5. She's saturating fine. Respiratory rate's still
Debbie,
good.
If you've got blocks around her head, do you still want me to keep holding her?
No, you can. No, if we've got all the blocks, that's fine. So breathing is
Just
fine.
checking your pupils.
The blood gas has come back.
Yeah.
The consultant has heard.
So lactate's come down, hasn't it, from 7?
The consultant
really
asked.
not
I
good.
think he wants to know what's happening because he heard there's a trauma. Has anybody called the consultant?
No, not yet. I'll call my burns consultant now. Can I borrow a phone, or do you want me to just pretend, or?
Can we get a blood sugar as well, please?
Right, you bastards, what's going on?
Hi, I'm one of the new registrars. My name is Debbie. We have an 18-year-old who 30 minutes ago has sustained flame burns to the torso, the abdomen, both arms and face, and was trapped in the room for say 30 minutes and 5 minutes, and then jumped out of the window. So we've started with C-spine, 100% oxygen. We've got the anaesthetist coming down immediately. Chest is expanding fine. Fluids, we've got the 4 mils per kilogram per total body surface area, and it's responding well to fluids. Catheterized and
How
good.
much fluid is he given?
We have given. We've given. We said she was 60 kilograms, so 60 times 4 mils per kilogram, starting from now.
She was hypotensive.
She was hypotensive, but now it's good urine output at 1 mil, and her blood pressure's good, and she's pink, and she's got good pulses.
Okay. So the response to
Fluids has improved, yes, and lactate's gone down from 7 to 1.4.
okay, good, and
good analgesia. So because of obviously the trauma, so we've got the trauma team, the gen surge team to come down. She's perhaps got a supracondylar fracture. We're going to do a full trauma series and fast scan, but it doesn't look like there's any other injuries. We'll obviously do the scan of her C-spine before we take that off.
and what was her GCS?
GCS is 13 AFPU. Yep, we're doing.
So we're going to scan.
Carboxy hemoglobin's just come back at 30.
Fine, so we've got the 100% oxygen on. So we're going to do C-spine, pelvis. We're going to do her left arm, fast scan for the abdomen, because I think there's a bit of abdominal pain at some point.
Okay. What else are you going to do?
So we're going to phone the burns unit and let them know that we're coming. I'm going to cover her in cling film for now.
The SAT is just beginning to alarm.
So that's a drop. So we just need to call the anaesthetist to make sure they are here by now. Because she was obviously trapped, so we do need to intubate as soon as we possibly can. And I'll let either IT or burns unit know.
I'm the
Hi.
anaesthetist on today.
Hi.
What-
I was just telling my consultant, 18-year-old who was trapped in a house fire. This was about 30 minutes ago for, say, 5 minutes, and trapped in her bedroom. There were actual flames. She caught on fire, and then she jumped out the window. But from your point of view, she's alert. She doesn't have any stridor. She's completely full senses, but she does have some burns around the mouth, a little bit of soot and some singeing nasal hair. We've got it in the C-spine because, but I think she probably will need, I'm concerned about needing intubation because of the fact she was trapped, and also her carboxy hemoglobin is 30, so
What time was the injury?
it was about, say, 20 minutes ago.
Okay. So you'd be concerned about the carboxy hemoglobin.
Absolutely.
And what else might you be concerned about, particularly if she's got very acidotic and hypoxic as well?
So inhalation injury?
Yeah, and what other?
Cyanide?
Say, cyanide.
Yeah.
So how do you test for cyanide? Probably.
You just treat it clinically.
Well, what will give you a good indication they might have a cyanide injury?
Respiratory rate, saturations,
Well,
and ABG.
yeah. What particularly in the ABG?
The pH? I don't know,
So
sorry.
acidotic. Okay, and they have problems extracting oxygen, don't they? It's a
Yes.
cellular poison.
Yeah.
So what would you expect the arteriovenous difference to be if you measured their oxygen saturation on an arterial gas and a venous gas?
So it would be a larger difference.
A small difference. No.
Yes, of
What's
course.
your
Yeah,
venous-
yeah.
If you do a
Of course,
venous gas, what's the typical sort of saturation? No, do venous gas. Yeah, 70 to 80.
Can we
Okay.
have drugs for the RSI,
So if
please,
it's
and the
less than
tubes? What
10,
size tube would you like?
Yeah, then she's just not saturating.
So
So, well, no, she's not extracting
No,
oxygen.
no. Yeah.
So what might you want to give her?
A high flow oxygen.
Yeah, high, well, that's got to be carboxyl, for the carbon monoxide.
Yeah.
What specifically could you give her for the
Cyanide.
cyanide?
Might make a start.
Yeah, so give some vitamin B12.
Okay.
And that will
Just pray the scenario for the
raise her blood pressure as well.
What? Sorry.
It will increase her blood pressure
Okay.
as well as improve her acidosis. There you go. There's your collar. Carry on. Carry on.
Okay. Cool. So, can someone keep holding her?
Maybe the general
And
surgeon can help you.
yep. And so, what we're going to do is we're going to. Do we roll and then put the collar on, or we put the collar on then we roll, don't we? So let's put the collar on first. If you're alright to just hold, we'll keep the oxygen on and we'll just slide it through.
Did you want some drugs or should I wait?
Yeah, we can give us some more. We'll give us some more.
Okay.
Would you want it on first?
Then I'll
That's for 89, so
Okay, we'll put it on now.
Get the tube
sort it
in.
out
It's
for the rest.
that way, isn't it?
I'm going.
Yeah, that's the inside.
That's the inside. Hold a second. That's the inside.
Yeah.
Okay,
That's
would you mind
the-
monitoring
that's the-
yours?
yeah,
Just
yeah.
That's the outside too.
So
A bit of pain, her heart rate.
Somebody's got three.
Gone up to 150.
we've got IV access. We can give her a bit more morphine. So you're alright
Would
to
you mind doing
lift
things
and
on
we'll.
holding the head?
You're
Is
right to
that
take it
okay?
from me when I push it through.
Yep.
You're right to just lift very slightly, just keeping it in line.
How much would you like me to give her?
Another 5, please, IV. And we'll just keep an eye on her saturations and her heart rates.
Still 89.
So I think she's about
Just measure your hand.
regular.
Super regular to full place.
Have you given morphine? You've been
Wait, take your mask off for a second as well.
Just give me a hand, would you, Steph?
Has the heart rate improved since we've given
Just try and get it to the regular one.
Yeah, it's about to come down. Do another blood pressure.
89%.
Okay, just push it in.
Yep.
Just put. There you go.
111.
Is it going down, is it?
Yeah.
And guys, well done. I think the scenario's over.
No, thank goodness.
Let's hear it from you first, participants, then faculty. How'd it go?
I wasn't the only person there.
It was much slower pace. I felt it was very measured, and we were trying to give consideration for every body system as we went. It was quite a systematic approach, with revaluations happening through. There was a lot of standing around and waiting for something to happen, which felt a little bit frustrating. But I wasn't quite sure what actually the next step would be anyway, because you were relying on anaesthetist to turn up, someone else to come. So you're kind of in that limbo state, waiting. But we were monitoring the patient, we were communicating. I think we eventually got the gist of, like, you can't just say I've taken the blood, you actually have to send them or ask for results. And
But do you do that in real life?
well, I take them myself, so I sort of kind of normally had run it. But yeah, so eventually I think we got round to it and the patient lived to that point. So I thought we did very well.
Kept her alive for 5 minutes.
She didn't get paralyzed as you're moving her neck, which is very good. Good. So how else? How did you find it?
It was fine. It was just frustrating because usually, if it was that'd be a trauma call, wouldn't it? She'd have.
She came in as a burn alert. She didn't.
Yeah,
you
yeah.
picked up the trauma call. You picked up the CSI. So good on you that you called somebody to check.
But it depends on the ambulance.
Yeah, depends on the ambulance.
If
Yeah,
it's a burn elsewhere, that's what it will come in as.
So usually it comes in like that, and you're good to pick up perhaps a shoulder, arm injury. So you would have then proceeded to secondary survey eventually. But this is what you got told, and this is what you get. And the robustness in your approach to assessing a patient is to remember, although you're the burns team, you're a good plastic surgeon, you're going to do EMSB proper and ATLS proper. And you're going to pick up the other injuries and get the other teams involved. That's key. Shamari, as your assistant, how's your new blood pressure cuff?
No, but I thought it was really good. Yeah, they did a very good job. Yeah, very systematic.
Did you, Sarah, something to say?
To be honest, it's quite reassuring to have quite a few of you at least talk to me at one point. It's not me just sitting there.
So they're good? Okay. Faculty, please?
Yeah, I thought it was very good. I thought you were actually very good. I entirely agree with the thing that was measured and stuff. The problem about medicine is, particularly as at different levels, particularly at junior levels, is that most of it is waiting around for other people to turn up, make a decision, etc., etc. So waiting is part of the game, I'm afraid. And so actually pretending you're busy while you're waiting is also good. So, but no, I thought he did very well. I think most hospitals, if you get a major burn in, that is then a trauma call. But obviously not in this scenario. I think you've got the patient comes in again, not a massive burn, who's actually quite profoundly hypotensive and acidotic, out with the severity of the injury. So you've got to think about something else apart from the burn going on, which you did. So intra-abdominal bleeding, external bleeding, which you look for. There was some neck pain, so it could be spinal shock, although you don't usually get such profound hypotension with that. Is that right, David? So, but then I think the other thing you've got to think about is poisoning. And you've got, obviously there's a carboxy hemoglobin at first, but you've got to think about cyanide poisoning. And the way you determine that is to look at the arteriovenous oxygen saturation levels. So you take out arteriovenous blood gas, and that's quite a useful one to know in that situation. That responds usually dramatically and immediately to some vitamin B12, some hypoxia but I think I was very impressed. You've obviously done ATLS. I was impressed that you could do a fast scan. As you said, I'll do the fast scan, so that was good. So that was very good.
I think involved appropriate people, called appropriate people at the right time. As you said, it's just the waiting then called you made the call, but until they actually turn up. And that's real life. So the consultant might be on the golf course or something, and the anaesthetist aren't always drop that out. There's big trauma centre. I mean, most major births now should go to a trauma centre, but we still going from Burton or places like that, but we just got dragged there as the nearest hospital. So they're not necessarily going to come into that sort of scenario.
We're also assuming that we could cannulate and stuff, so things like that happened really fast. And actually, in the major burn, you could be there till the end of the scenario. Cannulating.
Yeah, we'll let you off with that just so you can see the rest of the scenario. But you're right, because lots of times you do wait, but you did use your time. You kept on checking the SATs, you kept on updating the team. Sometimes we would. You asked for pain relief, I think appropriately. Then you figured out we have some more kit. You're trying to do the neck. I think you delegated appropriately. You asked for help. All of you asked for help when you wanted stuff. The anaesthetist, we expect them to come, and sometimes fast week nobody turns up. And you then rightly kind of remembered and said, well, let's call them. Your consultant happened to walk in because you heard it's a major trauma when you walked in. You introduced yourselves. I think at the start, you both introduced yourself. You didn't know each other. That can happen. I think you did well. Yeah? Happy? Ish? Learned something? You heard it from the expert faculty, so hopefully today you got a few technical tips on what happened. This patient did have cyanide poisoning. Okay? So yes, her tummy was fine. Thank you for saying it was alright. Her shoulder actually turns out to be okay. Just a little sprain because how she fell. Her wrist is a little sprained. She did not have a neck injury, but she rather had to clear it appropriately until she got her scan. And we do in our hospital do a trauma series for these. So just pop in the scanner. It's a really quick one, 30 seconds. Out they are, and you have a full picture. If it's also a head injury, she did not have a head injury. It's good you looked at the eyes and the pupils. That was important. She didn't have cyanide poisoning. You were going to give her hydroxycodone in the So high flow oxygen is key. And I like A, B, C, D, you keep on going back, because then that's key. In that waiting period, that's the thing that will save you and the patient. And then, we need the other teams to come in, we need to optimize your patient injury. And as a team, I think you did great. So well done.
I've just got one question. You know, when you actually assess in the burn, is that part of the secondary survey through that, or is it? I don't really know.
I think AMC is probably a primary survey for your EMSP.
Okay.
Is that right?
Well, it's A, B, C, D, E.
Yes.
So you've got to do your. Only when you've got exposure with environmental control can you fully assess the burn. So it's actually fairly low down the list.
Yes.
Those are going to die of a burn in their A&E department unless they've got an airway. So they're not going to die of burn shock, whatever. So actually assessing the size of the burn comes down fairly low. So airway, breathing, circulation, disability, so GCS and that. E, exposure environmental control. And that's when you assess the burn. Again, everyone has a slightly different. That's when you assess the burn side. Because then the next is F, which is fluids. So you do primary survey, so A, B, C, D, E, and your secondary survey.
I may like to make one comment, which is you all mentioned it on Browder. Nobody actually formally looked at it and actually went through it and calculated it to be precise. We'll say at 50 and 20. It happens. And I agree that usually your formal assessment is not until you debride the burn in theaters, particularly in children, and then you will get what the actual burn is. And that's why they say you sometimes use 2 people, like 2 seniors. That's what we do with the kids. And after the first thing to assess, but it would be nice to say, this is what they have, this is what we think is full thickness, this is superficial partial thickness, this is just erythema, so we will exclude it. I think it is 16%. And because it's 16% and she weighs 55 kilograms, I'm going to calculate this because she's an inhalation injury. I'm going to go on the higher scale of 4 mils per kilo parchment. I'm going to 4 mils times 60, times 55 times 16%, for example. Sense? That would just be nice. Let's break it up. When did your burn happen? Because that's what kind of at some stage you're going to have to be. I know we did the whole A, B, C, D, E. This is for the future, of course. When you're assessing your burn in real practice, you want to know how much fluid they have had, and you want to document your analysis. So you want to know how much fluid. And when I come in at night and she's still in phase 1 of her resus, I want to know how much she's peed and what's happened in case she starts drinking, particularly because they're dropping. Particularly because she was a lactate, she was acidotic at the start, and now we've fixed that, semi-fixed that, and we're in the process of fixing it. And then when she goes on to her second phase of resus in the next 16 hours, right, because we call it the first 8 hours, and we're going to give it a half, we might have to top it up because she has a high risk of inhalation injury, and these patients tend to have higher fluid requirements, so we might have to give her some bolus. So that's when we start thinking. And then the whole albumin thing is a topical concept that we for another day, but it'd be nice to just remember in your real practice that, yeah, we're giving her fluids, and sometimes it makes no harm to just give a liter stat, for example, in an adult because they can handle it. Definitely not in a child because you have to be very careful with weight. You don't want to put them into edema. But I think we have to just remember that when we exercise our resus protocol. But other than that, and just document. This is what she's had since the burn. These were requirements. We may always alter it because the picture is not, Parkland's phase 1 and phase 2, but it's really about being dynamic, getting a thorough understanding and feel for your patient, monitoring the urine output as they progress, and then you might have to top up the fluids. Do you agree? Oh, so just that. But
when
of
you've
course,
got somebody profoundly hypotensive like that, you forget about
It's something else.
liter of whatever you've got, see the response. So giving fluids like giving a drug. So it's a dose response, isn't it? So give them fluid, see what happens. Give them some fluid.
And we hadn't been able to roll her just yet as well, so I was very aware before we actually settled on a figure of percentages. You actually need to look at the back of the patient in case it's all also burn. So although we started the fluids, I think the reassessment of the extent of the injury would happen after you've actually rolled and seen everywhere else.
Absolutely. But this was a come for the day, like for the future, for your burns, to remember.